Good evening and welcome to the Minnesota Ovarian Cancer Alliance's virtual Living Well meeting on lymphedema care and treatment. I am Stephanie Gliniani, MOCA's Community Support Program Manager, and I thank you for joining us for our live presentation and Q&A session. Tonight, we will be learning how lymphedema is diagnosed, exploring treatment options, and learning ways to manage symptoms. We do have a handout available for you to use during the program. You can click on the handout tab and download a copy if you would like to follow along with us. If you have questions for our speaker during tonight's presentation, you can submit them through your chat box or also email us at info@mnovarian.org. Now I am so excited to welcome our guest speaker, Dr. Nancy Hutchison of Courage Kenny Rehabilitation Institute and Allina Health Cancer Institute. Dr. Hutchison is a nationally recognized lymphedema expert, and she serves on the board of directors of the Lymphology Association of North America and the American Society of Clinical Oncology Survivorship Committee. We are so happy that you are here with us to share your expertise. Welcome.
Thank you. Pleasure to be here.
Well, we wish we could be in person, but we're so happy that you're here joining us virtually. So thank you for that.
Well, again, thank you very much for having me. It's really an honor and a privilege to speak to you about ovarian cancer-related lymphedema, and I'm going to jump right in because there's a lot of information to go through, and I want to have time for questions. The most important thing to start with is what is the definition of lymphedema? It is a specific kind of edema. Not all edemas are lymphedema. It develops from an abnormality of the lymphatic system. So lymphedema can be primary lymphedema, and that is a genetic abnormality in the lymphatic system that can occur at any age, but it's most commonly in children and adolescents and rarely in adults. Secondary lymphedema is lymphedema that happens because of damage to a lymphatic structure, usually lymph nodes, or the lymph vessels that carry the lymph to the lymph nodes. And in our specific concern tonight, it's from cancer treatment, which is usually because lymph nodes were removed. That's called a lymphadenectomy, and for ovarian cancer, those nodes are removed from the pelvis, or radiation therapy to lymphatic vessels or nodes in the pelvis. So one thing lymphedema is not is too much body fluid that's overwhelming a normal lymphatic system. That's a different kind of edema, and a person can have both. And one of the things that makes it a little bit difficult in diagnosing lymphedema in legs is that there are so many things that can cause swelling in legs. So most adult edemas, including cancer-related lymphedema, have multiple factors involved that we have to sort through for treatment. So edema, swelling is a physical finding. It's not a diagnosis. It's a physical finding of swelling, and we have to figure out what's causing the swelling before we can treat it. So edemas are named by the system that's injured or damaged. So lymph structures injured or damaged is lymphedema. Vein structures that are injured or damaged are venous edema. Now, a person can have long-standing venous edema that starts to damage the lymphatic vessels, and that's called phlebolymphodema. But phlebo refers to veins. So the first word is the system of original injury. And then lipedema is edema from fat deposition, and that can either be a genetic abnormality of fat deposition or chronic severe obesity can lead to injury to the lymphatics, we call lipolymphedema. But the first word is lipo. So cardiac edema is edema that comes from heart not pumping fluid effectively, and sometimes it leads to congestive heart failure. But that's the kind of excess volume related edema that is common, and that's what diuretics are used for. And we'll talk a little bit more about that later. Other forms of edema that can happen are from kidney damage or abnormality, protein deficiencies, and some endocrine disorders. And the main one that we as healthcare professionals need to be aware of is severe untreated low thyroid, not treated hypothyroid, but people with untreated hypothyroid. And a lot of people have more than one of these. So edema itself as a physical finding is common after ovarian cancer, but it usually is not lymphedema. So this is a list of all the potential things that could cause swelling that we want to sort through before we say, oh, this person has lymphedema. And one that's very common is blood clots in the legs or the pelvis that we call DVTs, deep venous thrombosis. But there can also be a stricture, which is a tightening or a narrowing of a vein, and that usually would be in the pelvis that comes from surgery or radiation. It can be a bowel problem, it can be bowel obstruction, it can be fluid in the abdomen, which is called ascites. Could be kidney or heart problems, like I mentioned. It could be a cancer recurrence that's blocking the lymphatic vessels or nodes. Joint problems are common causes of swelling in the lower extremities, and then medications can cause swelling. The one we usually look for is amlodipine, which is used for high blood pressure. So it's a common cause of leg edema, and it's a common drug. Gabapentin, which is a nerve pain drug, is something that a lot of people that have chemotherapy neuropathy are on. It's a rare cause of swelling, and it's a minimal cause of swelling, but it's something just to be aware of in some people. And then steroids are common, and of course those are given a lot with chemotherapy that can cause swelling. So again, we look at everything. The swelling after ovarian cancer can be in legs, abdomen, and genitals. And the thing that you should be aware of as you're being sent for treatment is that the treatment that's done by physical and occupational therapists is often referred to as lymphedema therapy. That's really a misnomer. The real term for it is decongestive physical therapy or decongestive therapy. It can be done by occupational therapists because it's to reduce the fluid in the tissues. And that, quote, lymphedema therapy, any swelling responds to decongestive therapy, but that does not make the diagnosis lymphedema, which is why I prefer not to use the term, except that I did at the bottom. One of the most frustrating things, I think, for ovarian cancer patients and survivors is that abdominal swelling is usually multifactorial, and it does not respond to the traditional decongestive therapy because our treatments are more for the external lymphedema and not for the internal edemas. So there are other things to look for there. About 20% of individuals after pelvic lymph nodes are removed, so that would be ovarian and other gynecologic cancers, will develop leg lymphedema. 50% of individuals that have lymph nodes removed from the groin, which for the gynecologic cancers would be vulvar cancers, will develop leg lymphedema. So signs are things that we see and symptoms are things that we feel. The signs and symptoms are the things that bring people to healthcare professionals so that we can create what we call a differential diagnosis. And the differential diagnosis is that whole list of things that I just showed that can cause leg swelling. And then it's my responsibility to work with the individual to sort through those to figure out which things are potentially reversible and what's lymphedema and what might be something else. The signs of lymphedema are swelling, a pinkish sometimes color in the swollen part, and the symptoms of lymphedema are usually achy, heavy, and sort of a low-level pain or discomfort. Signs and symptoms that are not typical of lymphedema are pain. More severe pain can be from a number of other conditions, such as cancer recurrence, lumbar plexopathy, which is nerve damage to the nerves deep in the pelvis. It can be from a deep venous thrombosis, a deep blood clot, joint problems or arthritis. And peripheral arterial disease is blockage in an artery to the leg, like atherosclerosis that affects the leg artery, or neuropathy. And all of these, of course, could exist along with lymphedema, but if the lymphedema is treated and the swelling goes down, this pain may not go away because pain isn't usually a feature of lymphedema. It is uncomfortable, but if you're talking about pain, we should be looking for something else. Weakness is the same thing. Now, the part might feel heavy and difficult to lift, but weakness where we're saying the part won't move, that would be something we'd be looking for something else. The bluish color goes more with a vein problem or a blood clot, and red color would be more infection or dermatitis. And of course, all of these can exist together, which makes it, again, a bit confusing at times. So once a person comes in and we've formulated the possibilities for what could be causing that set of signs and symptoms, there would be an evaluation using laboratory and imaging. And it can be quite extensive, which is often disconcerting to people because they might say, well, it's just leg swelling. And the little bit of garden variety leg swelling that maybe someone has because they've been on their feet all day, yeah, that's not as serious of an issue as somebody who develops new onset leg swelling after an ovarian cancer diagnosis. So it is a big workup. And we might have to usually start with the kind of Doppler ultrasound where the person is lying down. That's looking for a blood clot. That's just your first thing to say, let's make sure it's not a blood clot in the leg. You can only see the leg. Then we might do a standing up ultrasound to see if there's vein valve problems. So we call that venous insufficiency, and those are varicose veins, if you can see them on the outside, but sometimes they're on the inside and we don't see them. So that's why we would do a standing Doppler ultrasound. There might be a CT scan or an MRI scan, and that's to look at the abdomen and pelvis, looking for lymphatic obstruction, you know, any kind of cancer occurrence. It can look for bone, vascular, or other tissue abnormalities. And then there's a special kind of MRI and CT that actually is able to look at the pelvic veins. Sometimes we can do pelvic ultrasound and see pelvic veins. Sometimes we have to do CT or MR. This doesn't show up on the ultrasound where one is lying down on the table and they're doing an ultrasound of the leg. So that's something that I would commonly do because it's frequent in individuals who've had lymph nodes out of the abdomen and or radiated. There are more interventional venography types procedures. There actually can be therapeutic if there is, say, a blood clot or stricture, that they can go into the vein and fix it. But then we're also going to look for all these other causes of swelling that I just mentioned, like the heart. You do an echocardiogram. You might do a soft tissue ultrasound, and that might be to look for a mass. That would look for a large fluid collection that's called a seroma or a lymphocele, and then all the labs. To actually make the diagnosis of lymphedema, we would do a lymphatic scan, and that's called a lymphoscintigraphy. So it surprises some people that the incidence of vein problems in ovarian cancer survivors is much higher than lymphedema. So that's usually my first go-to if somebody has leg swelling, and it can blossom after the surgery and or radiation. Might have been there, but it wasn't showing up, and then all of a sudden, because of these other stresses on the system, this shows up. But we know that venous reflux, which is the varicose vein, the valves don't work, is extremely common, and the risk of having a blood clot in a vein is 3 times higher in people who have varicose veins than the general population. And of course, the cancer treatment itself causes a risk for blood clot, and then blood clots can damage the valves. So the other problem is that vein problems are much higher in women over the age of 50. they occur in 50% of women. And sometimes they're not really a problem until after the cancer treatment. So we really have to be looking at this as something that might be causing the swelling and not just assume that it's lymphedema. So this is just a quote out of a journal paper from 2019, and this is published over and over and over again, stating that the clinical signs of lymphedema, and what I mean by that is looking at the outside of something, are unreliable in making a correct diagnosis of lymphedema. You can't eyeball a leg that looks swollen and say, oh, that's lymphedema. That is unreliable in at least 1/3 of individuals. So that you have to look at the system that would be abnormal, that would be the lymphatics, with a lymphoscintigraphy scan. Before I get into what that looks like, I want to say that lymphedema is not just edema either. It's very different from other forms of edema because it's lymphatic organ failure. And that lymphedema, the lymph system exists in the linings of our body. I call it your outside circulation. It's under the skin, in the dermis of the skin, and it's on the inside linings of the body that we call the endothelium. And because it's made up of protein, I think of it a little bit like Jello or gelatin. When it's in a liquid form, it's moving through the lymph vessels quite easily. But if it sits around and becomes stagnant, it'll set up like Jello, and then it becomes thicker, and we call that solid component lymphedema, which is much more difficult to move, which is why we like to try to get at it early when it's still in a liquid form and easy to move. The other thing about lymphedema is that it's part of our immune system because it's carrying bacteria, viruses, it's those T cells that are in the lymph nodes. This is part of our immunity. So when foreign materials like bacteria that are on our skin are not being carried to the lymph nodes, it makes a person more at risk of developing a skin infection that's called cellulitis. In the later stages of lymphedema, where it's solid predominant because it's been there for a long time, then it can lead to more pain because it will bind down the tendons and impair mobility more. But all of these symptoms are mitigated. We don't say cure because we can't cure it, but we can definitely improve it or reduce all of these symptoms by a treatment called complete decongestive therapy. So that's that lymphedema therapy, and we call it CDT. And why is it complete? It's because it has multiple components, including bandages, lymphatic drainage, massage, exercise, and other things that I'll show you. Other treatments, medical treatments such as diuretics, are not effective for pure lymphedema because it's under the skin. If there's no component of medical edema, we wouldn't use diuretics. But if a person has other diagnoses like heart failure that they need diuretics for, then of course they would take diuretics for that. It's just not the treatment for pure lymphedema. So again, I just want to go back to the diagnosis of things. I think it's sometimes shocking. It seems to be in my practice that we should have to image the lymphatics and not just look at a leg. But just think about how we diagnose heart disease now. You know, going through history, there was just putting your ear to the chest, and then there was a tube, and then there was the stethoscope. But no one now would think of committing somebody to any kind of cardiac surgery or intervention without doing an echocardiogram and actually looking at the structure of the heart. And that's what we do with lymphoscintigraphy. So over on the right side, you can see 2 different lymphoscintigraphy studies of the legs. When we do the legs, the injection is in the feet, and it's just under the skin. I say it's a little bit like a TB test. It's a little bit more than that, but it's just under the skin because that's where the lymphatics pick up the fluid. And it's a tag on just a protein molecule that's tagged with a radiation label. It takes about 60 to 90 minutes to do the test because there's an immediate image and a delayed image. And it's important because you can see right here, and I'll show you in the next slide, that a person can have swelling in their right leg. So this is the right leg, and the reason you know that in this picture is because when the tracer goes out, you see the liver, and the liver's on the right side of the body. So you see it going through the liver. That's the right side. So what we are seeing is people with leg swelling with a completely different pattern of abnormality. This person on the right side has a lot of collected lymph that's not moving in the lower leg, but you can see lymph channels pumping all the way up to that person's lymph nodes. And by the way, if you look at that person over on the right-hand side, there are no functioning lymph vessels at all. It's all stagnant lymph. And those lymph nodes in the groin that are not taken out in pelvic surgeries, they're not lighting up. They're there, but the lymph system is not working to pump fluid anymore. So that's going to tell us a more aggressive or intensive treatment is needed. And that's how we can use these scans to help us know what kind of treatment we need to offer. So again, we look at a swollen leg. Now the person in the middle, these other two I just showed you, the person in the middle has some thigh swelling on the left side. And you can see that because there's this shadowy, stagnant lymph sitting there. But otherwise, that system looks pretty good. And so we see that there's a lot of functioning lymph vessels, but we also know that that's a little bit more difficult part of the body to compress up around the top of the thigh and the abdomen. But that's where the problem is. Now, there are other imaging techniques that are emerging, and the one you hear the most about is called near infrared fluorescence. It's sometimes shortened to ICG, which is indocyanine green, and that's just the tracer substance. This uses an optical imaging device that's like a night vision camera, and the injection is put in several places in the subcutaneous tissue. This technique can image the tiny, smaller lymphatic vessels under the skin. The lymphoscintigraphy looks at the deep collectors that the skin lymphatics dump into, and the lymphoscintigraphy we just saw can see lymph nodes and whether the lymph is going there. ICG cannot see collectors or nodes, and it's mainly used now in lymphatic bypass surgeries, where the surgeon is looking for a way to take a small vein and hook it to a lymph vessel and create shunts. This is not covered by insurance as an outpatient procedure. It's not done in radiology departments, so it's not widely available except in lymphatic surgeons. Some do it in the office and some during surgery. But it is an important technique to keep our eye on because there may be a time when it is more available, and it would be a good companion scan to lymphoscintigraphy to see the whole system. What's the small lymphatics and the deep lymphatics. So the A person has had a lot of damage to their skin lymphatics. They're all blurred out, blunted. We call this a stardust or a splatter. The linear one over in person B, those are normal pumping lymph channels under the skin. That's called the linear pattern. In order to do a lymphatic bypass surgery, the surgeon would have to find some of those linear vessels to bypass. Now in the clinics where we go to the physical and occupational lymphedema therapists, they're called CLTs, Certified Lymphedema Therapists, who do complete decongestive therapy. So you'll see that CLT term around. That means Certified Lymphedema Therapists. They've gone to a course that qualifies them to do this special treatment for lymphedema. And what they would do in the clinic is stage the lymphedema. So staging, just like cancer, is how far it's progressed. And the diagnosis might be cancer, but the stage might be 1, 2, 3, or 4. Similarly, with lymphedema, we make the diagnosis with imaging, but we stage it by touching the tissues, and we call that tissue compliance, and those create stages 1, 2, 3, and 4. And that stage 2 is what we usually comes to our attention, because that's when the swelling doesn't go away when you elevate the limb. It's sort of staying there and starting to blunt out our normal bony landmarks. And then there's a severity by volume. So that would be how increased the size of the limb is. That creates the stage. So the soft tissue assessment is to see if the lymphedema is more solid component or more liquid component. And as it progresses, it becomes more solid if we don't treat it in the liquid phase. And pitting helps to show if you push on the tissues and they dent, that's called pitting. And that means there's some liquid that can be moved with decongestive therapy. When it progresses a little bit more to what you see in that lower with solid component, we start to see denser tissue that doesn't pit. We call it a stemmer sign when you can't kind of pull up the skin. And that gives part of the tissue stage. And then for the volume, there are a number of ways that measurements are done. Most commonly in clinics with PTs and OTs would be a series of tape measurements at intervals up the limb, and that is calculated by a mathematical formula to a volume number. They used to do water displacement. We don't do it anymore. Some places do bioimpedance, which is kind of what you would do at a health club to see how much water is in the tissues, and then there's a parameter. But most commonly, it would be a tape measure. So then with the diagnosis of lymphedema and the staging, now we move into, okay, we know how to treat this now because we know what we're dealing with. So in the stage 1 and early stage 2, this is a little bit of swelling. It's more liquid. Sometimes you can just treat that with a lighter compression stocking. And if we do the lymphoscintigraphy and we see that there's a lot of good collectors pumping, then we know that sometimes if we just reduce the volume, get some of that fluid off of there, maybe the person won't even need long-term compression, or it would be light compression. Now, sometimes that will go on and progress in spite of a person doing everything right. And that's usually a genetic predisposition that people have because of what we call vascular repair genes. So we're just learning more about why some people progress even though they do everything right. But it's much less progressive when it is managed in a more liquid stage. In stage 2 and stage 3, now we're getting into that denser tissue. It might be a little doughy like clay. And for that, you do need to do decongestive therapy to reduce the size of the limb before putting it into a compression stocking, which we would think of a little bit like a retainer after the braces. But that would typically have to be worn continuously because our lymphoscintigraphy has probably shown that there's a non-functioning or poorly functioning lymphatic collector system, and it needs something to help the lymph move. So when decongestive therapy with a lymphedema therapist is done, it can downstage the severity. So the volume will reduce, and sometimes the tissues become more pliable. But it doesn't change the underlying diagnosis. It doesn't change the lymphoscintigraphy that has already told us that the lymph system isn't working. The compression garment is doing the work of what the injured collector system would do. Lymphedema compression, we want to hold and contain, not squeeze. And so once the lymphedema is more like a stage 2, it's a little doughier tissues, these circular knit elastic garments don't work. They're too constricting, they're too tight around the ankle, and they don't hold those larger parts of the limb. And for those, we use something called an inelastic garment, non-elastic garment, or a flat knit. So if the lymphedema stage 2, it doesn't go down when you elevate overnight, it's starting to have a little bit more doughy feel to it, that's when complete decongestive therapy we do before getting a stocking. If it's a lower stage, like a stage 1, early stage 2, might be able to go straight to a stocking because we don't need to reduce the size first. And that is complete decongestive therapy. It involves a special form of, people think of it as massage, but it's a stimulation to help the lymph vessels to contract and move fluid to other territories. And then the short stretch bandages, which look like ACE wraps, but they're layered compression wraps to reduce the volume. It's in phase 1, which is what is done in the therapy department, and phase 2, which is done as home management. So don't mix up phase 2 and stage 2. This is complete decongestive therapy, phase 1 in the treatment with the therapist, phase 2, now the person is going to take this and do this on their own. And so it would be usually some form of daytime compression and sometimes a nighttime compression. And here I've shown garments for every part of the body, but obviously we're talking about legs or genitals, and I don't have a genital compression garment in here, but we have those as well. A big takeaway is that exercise is really important. Compression alone is not enough to manage lymphedema. Lymph is moved around the body by muscle movement and deep breathing. And if we have people who cannot move their legs because of paralysis or something else, that might be, there usually are some forms of exercise that can be prescribed by a therapist. So lymph is moved around the body by muscle movement and deep breathing. So we want to do a full exercise program if at all possible. And there's many types of exercises, but sometimes that would be something that the therapist would help to move into after getting the lymphedema under better control. So pumps you hear about are pneumatic compression pumps. The one in the lower part is one of many types of leg compression pumps. These are second-line treatment. They're not a substitute for correct garments, which would be the daytime and nighttime garments. It's added for people that have more severe forms of lymphedema that's not controlled with correctly prescribed day and night compression. And insurance companies require a very high degree of documentation of failure of standard treatment before they will pay for that, for a compression pump. So I just want to show you quickly a case report of an individual. If you look right in the middle, that's her lymphoscintigraphy. And you can see her standing, that her thigh was enlarged, and this is a patient who had ovarian cancer and had lymph nodes removed from the abdomen, and I don't recall whether she had radiation or not. But one of the things I do is stand people up, because you can often see the varicose veins start to show up when people are standing. So she's standing there in the second from the left picture, and we see those varicose veins start to fill down in the calf, which is another reason we also have to look at not just the front of the leg, but the back of the leg. And so with that in mind, that's fixable. So I sent her to a vascular surgeon or vascular medicine doctor, and you see that he, in this case, is putting a wire into the vein and closing off one of these incompetent valves. So I just have some volume numbers there in terms of showing the reduction that she got just from closing those veins, because if there's venous incompetence and lymphedema at the same time, both systems are impaired, and extra fluid is being sent to the lymphatics that doesn't need to be, because the veins can be fixed. So then she was able to be managed with a more sheer form of pantyhose. Now with lymphedema, and especially in those lymphedemas up around the thigh, it will often get its own set point and not go back down to what the other side was, which is always frustrating. But medically speaking, it is medically acceptable as long as the tissues are normal compliance and there are normal contours, yes, we would like it to go all the way down, but that often is not the case. So this is medically acceptable and managed with a nicer stocking that she was satisfied with. And then these are the lymphatic surgeries that you may be hearing about. Lymph node transplants that are VLNT, lymph-venous anastomosis, the shunts that I mentioned, where a vein and a small lymph vessel are sewn together. That's a microsurgery that's done under the microscope. That's why they look for those little linear vessels. There can be lymph vessel transplants where a flap is transferred. Those are lymphatic reconstructive surgeries. That's where they're trying to rebuild more lymphatic capacity. But there's also lymphatic liposuction for somebody whose limb has progressed in size and has more solid component. Just removing that thickened tissue will often produce a very nice result, and then the person would still need a compression stocking, of course, to maintain it. It's really important with surgeries to have comprehensive care with a certified lymphedema therapist before and after surgery. The results are not good without before and after care. And there are many lymphatic surgeons around the country and many very qualified, but there aren't as many of them who are collaborative in working closely with your local lymphedema therapist. And those are the ones I like to work with. People often ask about adjunct therapies, acupuncture, cupping, deep tissue massage, myofascial release, dry brushing, diets, vitamins, nutritional supplements, vibration, kinesiotape, etc. These may or may not help lymphedema. They're often kind of helpful in stage 1, early stage 2 when it's more of a liquid. They don't substitute for garments in almost all cases except stage 1. Some can be harmful because they can draw fluid out into the subcutaneous tissue where there's already impaired lymphatic drainage. And that may need to be done on more fibrotic tissue. Always should be done with a lymphedema decongestive therapist who will then be able to move that extra fluid out that accumulates. The best adjunctive therapy is exercise. The muscle pump with a compression garment, you can't beat that. So spending a lot of time doing a lot of these other things, if you had one thing to pick, exercise would be it. So the first thing to say is it's a very distressing condition. We all know that, and we really want to help people. But the most important thing really and truly is healthy bodies and minds. Because the condition, which is distressing to live with, can be managed, but we have to take care of ourselves. And the one thing that works the best is compression. The rest of it are other ways to kind of add icing to the cake. So we work with certified lymphedema therapists for the decongestive therapy, for changes in your health that might be affecting your swelling, for advice and treatment with exercise, for advice about adjunctive treatments, and oftentimes for advice on when to see a doctor. When would you consider seeing a lymphedema physician like myself? You and your therapist are not having success with your management. Maybe there's other causes of swelling to diagnose and treat. Haven't had imaging. It's a complex medical diagnosis. You know, there's combinations of things going on. In a situation where there's metastatic disease or recurrence that might need some help from a physician to manage the lymphedema, advice about lymphatic surgeries, or having a surgery on the lymphedema extremity, like having a knee replacement or something, or you just want a second opinion to sort of help you work with your therapist. But the most important thing is to find a certified lymphedema therapist in your area. And if your physician has determined that there's not a blood clot or a cancer recurrence, it's pretty clear what the diagnosis is. It's fine to start reductive therapy with a therapist. That's just fine. and don't have to go straight to imaging, just to see if you can get some reduction. And then they'll help with compression garments, exercise, and all of the things we talked about. But then if there's more that needs to be done to get an actual diagnosis, think about some of these other things, then they would suggest a physician for you. Really important with lymphedema to individualize. It can be very mild, requiring very little self-management. Just like any other condition, there's less severe and more severe. You just have to know your own situation and get comfortable with your care team. And the most important person on that team is your certified lymphedema therapist. And then there's just no one size fits all. It has to be individualized. It's a complex disease. I think I've shown you that. That's not a reason to be frustrated or think, oh my goodness, it can't be treated or managed. That really is not true. It's to help inform people that sometimes when the results are not coming that are hoped for or expected, there may be some other things factored in to look at and to make sure that we take care of. And that's why we really consider the team approach to care to be so important. So I thank you for your time, and I hope if there are questions, we have time to answer them. I'd be very happy to do that. Thank you.
Oh, thank you so much. This was just a wealth of information, and it was a lot. I know that we could talk about this for hours. So
It's a lot.
we appreciate your time, and we do have questions that have come in. If there are others that have questions, I am watching my chat box, so please keep those coming if you do have questions, but we will get started right away. So our first question is, do diuretics have a negative effect on the body if you have lymphedema?
Not usually, no. There used to be I think, theory that if it was pure lymphedema and you gave people diuretics, that it would dry out the tissues and possibly make the lymphedema worse. I think we really don't know that to be the case. I think what we have found is that sometimes people will go to a physician that really is not as familiar with lymphedema and they give diuretics. Well, they just don't work. And, you know, it could drop the blood pressure or, you know, have other side effects from a diuretic. So if it's just being used for lymphedema, it's not going to be effective, but it's not really harmful unless we're using them to the extent that it's causing other problems like drying out your kidneys or something. But there are many people who do require diuretics for other conditions. So I think it's really just a matter of having the right treatment for the right diagnosis.
Okay, perfect. Thank you for answering that. The next question, which I know you touched a little bit on exercise, and I know a lymphedema specialist would be able to help, but this person is asking how to know how far to push it. Having a hard balance of, learning how to try to exercise, but is there a point where, this might be a tough question to answer, but how to know how far to push it when it comes to exercise?
That is a really hard question because it's the problem with legs in general. So age is a factor, and what we call comorbidities are a factor. So if I have a person who's had, knee replacements and arthritis in their hips, lymphedema is going to, obviously make it harder to exercise, and it's already hard to exercise in some cases. Sometimes if you've had tendonitis, and the lymph is sort of getting around some of the tendons, it can flare up tendonitis. So it's really a matter of working with a good therapist to ferret out what's causing the problem with exercise and eliminating that, because the reality is there's not too much exercise with lymphedema. Okay. A person can do anything and not make their lymphedema worse if they don't have other conditions that need to be sorted out and fixed. But exercising in a compression garment, I mean, people compete in marathons and, you know, all kinds of exercise. So I think the other thing is to say, you don't have to be a marathon runner, but exercise should be a part of the regimen, something that's moving your legs, whether it's a stationary bicycle or walking. So there's those people who really, really, really want to do a lot of exercise, and we need to make that happen for them.
Yeah.
And then there's those people that are just saying, well, what do I need to do just to manage my lymphedema? And that would be the usual 30 minutes moderate intensity cardio exercise 3 to 5 times a week. So that's why other factors come into it. And I hope I've sort of answered the question.
Yeah, you absolutely did. I think it goes back to individualized. I mean, everyone is different. So it's definitely a hard question to answer too. So thank you for that. And if people have questions, keep them coming. My next question is, my doctor hardly mentioned lymphedema as a possible side effect. What can we do to talk about this more or educate to prevent lymphedema? It's a good one.
Well, this is a really good question. And since I've been treating in the field of lymphedema for over 20 years, I could feel like a failure that this is still a question.
Yeah.
I feel this is a failure of medical education. I think that traditionally oncologists, radiation oncologists are not taught about lymphedema. And so if you didn't learn it in your training, it may not exist in your head. And I do believe that there are many times that patients have taught me things that I didn't know, and I think you have to speak up. I'm very grateful for, you know, organizations like the Minnesota Ovarian Cancer Alliance and Learn, Lymphatic Education and Research Network, National Lymphedema Network, others. And of course, there is a shout out to our local support group, My Lymph Twin Cities. Look them up on Instagram, or, you know, ask people at MOCA. This is our collective responsibility, but, you know, one of the things that I've tried to do is emphasize the importance of medical education in oncology. But we are still obviously not there.
Yeah. Yep, absolutely. Thank you for that answer. Next question is with insurance. I'm sure this is probably a tough one too, but some of these treatments or therapies, if they're not covered by insurance, do you have recommendations to help push for an approval for a pump or for a surgery if it's appropriate?
Well, each individual piece and component of a treatment will be treated differently by insurance, much like it would be any other condition, whether there's a surgery or a medication or a therapy or an injection. Yeah. So they're all going to be individualized according to that insurance carrier's protocol. So I'll start with decongestive physical therapy or occupational therapy. That is generally well covered by all insurances, but it's temporary, and then you move into the self-maintenance phase. But it's according to one's insurance benefit, but Medicare and all insurance companies cover it. If you have a high deductible plan and you've got a $5,000 deductible, then you will pay out of pocket for it until you meet your deductible. So these are the problems with health insurance in general. If we move into compression garments, most private insurance companies do cover compression garments to a variable degree. That is the responsibility of the physician who orders the therapy to write the prescription for the garment and to write a letter of medical necessity if needed. Now, Medicare does not cover, because we all know that there's a glitch in the Medicare law, which is why the Lymphedema Treatment Act and the group that is working with the Lymphedema Treatment Act is continuing to try to get that law passed. But until then, Medicare won't cover. If it's a private insurance company in your state that is not covering compression stockings, you should complain to the State Department of Commerce, because it is clear that compression garments are a replacement for an injured system, and that is covered under the Social Security Act. So this just requires a lot of haranguing, unfortunately, but that's the truth. And then pumps, have their own set of guidelines that each insurance has. So it is up to the prescribing physician to see if your insurance coverage covers for your condition. And I am many times asked to write letters of medical necessity for insurance companies that have clear guidelines that they don't cover it. So that's an appeal on the part of the patient. You get a denial, and like any other treatment, then you go to appeal. It's all very cumbersome and it's terrible. I'm just telling you the truth because I've dealt with it for 20 years. Then if it's surgery, that is the surgeon's responsibility. You would have a consultation with a surgeon who does lymphatic surgery that your network has approved you to see for a consultation. They will propose a surgical plan, and that surgeon, just like a knee replacement, a shoulder replacement, or any other surgery, that surgeon has to work with the insurance company to state why they feel that you meet the criteria and then to run the appeal. So each component is determined separately. But the first thing to do, obviously the most important things are to work with a certified lymphedema therapist and get into compression. And then the other things can roll out as needed. And there are forms of compression, of course, that one can purchase. I realize there's a lot of out-of-pocket costs for this, but that's our job, to try to help people find alternatives when perhaps the most expensive alternative is off the table.
Absolutely. I think that answered the question great. I know it's a very complex question and answer, so thank you. That kind of led into the next question, which might be our last, is finding a certified lymphedema specialist. So is there a best way to go about that? And then someone had asked, are you seeing survivors and patients in person right now, due to the pandemic? Are you seeing people in person?
Yes. I am seeing people in person. I actually almost never now let people come virtually because it's almost impossible. I had no choice when people couldn't come in, but it's really a very difficult condition too. I've had people trying to stand up on a chair that's tipping over on a camera, no, it's just, no, you need to not do that. What was the other part of the question? Am I seeing
the best place to find a certified, if you have any recommendations?
Well, the best place, so not all certified lymphedema therapists have taken an examination called LANA, Lymphology Association of North America. That's the board I serve on that writes an examination for certified lymphedema therapists who want to go the next level and pass a certification test. Those people are available on the LANA website. It's clt-lana.org, or you can just Google Lymphology Association of North America. So they have a map, and you put your zip code in or whatever, and it will show they're called CLT-LANA. They're certified lymphedema therapists who pass the LANA. So that's the first thing, because that person's gone the extra mile. There are many qualified CLTs who maybe didn't take the LANA certification. They're a little harder to find, but Google works well. And often if I'm looking for somebody in an area, when they ask me, I will Google, I don't know, Butte, Montana, certified lymphedema therapist. And if it doesn't say, you call the PT department or the OT department, and you say, do you have any therapists there who treat lymphedema? Okay. And sometimes they'll say yes, and then I ask, are they certified? Have they taken an extra lymphedema course? And they're all over the place. If you find a LANA certified one, that's the easiest way to do, is to go to the LANA website. The reason you can't find a CLT in one place is there are a number of qualified training courses that the therapist then can take the LANA certification. So all those different training programs keep a list of therapists, but that's too hard. You can just look for them by asking your local PT department.
Perfect. Okay.
And I should say OT too, because there's a lot of OTs, but in our system, all of our lymphedema therapists at Allina now are PTs, but in many areas, they're all occupational therapist OTs.
Okay, Perfect. That was helpful. And we can put that information too with, that website with our information as well.
Great.
That is it with questions. I don't know if you have any last words or anything you want to share, but we really appreciate, your expertise and your knowledge. And this was just a wonderful, wonderful meeting. And we appreciate your time so much.
Oh, thank you so much. I mean, it's been a pleasure, and my only last words are reach out. And if you're not getting the help that you need, keep asking for it. Contact MOCA, contact the lymphedema support groups that are around. And actually, on the Allina website, they are starting to put listings of lymphedema support groups around the country to help people. So that Allina website, Lymphology Association of North America, also has some resources on it that you can find things. So just don't give up. That's all. Thank you so much.
Wonderful. Thank you. And I want to thank the audience as well. We hope you enjoyed our meeting tonight and our presentation. I do just have a couple announcements before we go. I would like to say, if you are new to MOCA, please know that we are here to support you. If you're a survivor, a family member, a caregiver, we have monthly support groups. We have a mentor program, cares kits, and you can find all of that information on our website at mnovarian.org. And before I go, I would like to invite you to MOCA Awards Night, which is coming up on Tuesday 9th at the Wilder Foundation in St. Paul. We will be presenting our Dream Awards to survivors. We'll be announcing our healthcare awards and scholarships, presenting our new National Early Detection Research Awards, and also honoring our top Home Teal Strides fundraisers and MOCA supporters. Our awards night is free to attend, but we would ask if you RSVP on our website at mnovarian.org. And for those who are unable to make it to the in-person event, we will be providing a live stream of the MOCA Awards on our Facebook Live, and then sharing a recording after the event on our YouTube channel. And then this Living Well meeting will also be recorded. It's recording right now, and we'll be posting that as well, and the handout at mnovarian.org. So thank you again, and we will see you next time.